From WRAL News, this is Focal Point.
It sounded like a good idea. Make mental health care in our state better through privatization.
I think we had this vision that privatization would be bigger, better, cheaper, more cost-effective, all that. I don't think that that's been the case so far.
State funds were supposed to support a network of private providers to meet the needs of patients in every community.
That, unfortunately, was not possible because of our fiscal crisis,
leaving many of the mentally ill without the services they need.
We have more people now who are falling through the cracks than we did before.
More of them ending up in hospital emergency rooms.
Every day, morning, noon, and night, 24/7.
More of them ending up in jails.
It's a criminal system, not a healthcare system.
More of them ending up on the street.
What kind of therapy, medication regimen are you going to do with somebody who's living under a bridge? I mean, that's absurd.
Some of the mentally ill who can't get the help they need end up dead.
It's a system that doesn't support you when you need it, and there's no hope in the system.
A system that some say is focused more on saving money than saving people.
The mental health, developmental disabilities, and substance abuse system in this state is not serving those it was designed to serve, it's serving those who designed it.
When the legislature decided to reform the state's mental health care system, the idea was to transform a wasteful government monopoly into a community-based system where private companies would provide care. Hopes were for a more efficient system that would serve more patients at a lower cost. But even reformers say too many patients are still unable to get the services they need. Our focal point, why so many people are now saying it may be time to reform the reform.
Okay, thank you. You have a good day.
Charlene Lee has bipolar disorder. It's a mental illness that causes sudden and severe mood swings.
I felt isolated, and I would feel like I was no good, like life had no meaning for me, and actually it didn't. I've actually cut myself in the past, and hi there. Hello.
She says the medications and weekly therapy she got at her local mental health center made it possible for her to function.
And when it became privatized, I was informed that I could only see my therapist every other week, mainly because I had no insurance and no way of paying for my bill to go there.
Charlene also depended on a community support person who helped her with a variety of other needs.
But they ran out of funding for her, and they started laying people off, and so I no longer have a community support person.
Chantel Brown's bipolar disorder lapsed into a psychotic episode so bad that her mother had her committed to the psychiatric unit of a local hospital.
I became aggressive while I was there, and they couldn't handle me anymore. So, like most hospitals that can't handle you, they call the sheriff's department and handcuff you and take you to Umstead.
She was in John Umstead State Hospital for 3 weeks.
I was discharged from Umstead with 1 week's worth of medication. I just had no support here. You know, I couldn't get in to see a doctor in a timely manner. I wasn't going to have a place to live. So I had no choice but to go back home with my parents.
Back to Mississippi, where she found the help she needed. Mental health advocates say too many people in our state either can't get the services they need or have had them cut, especially people not covered by Medicaid or private insurance.
There's been too much change and not enough funding for the services that we know work.
The change started with the downsizing of state mental hospitals, reserving beds there for only the most seriously ill patients. The state is closing Dorthea Dix and John Umstead mental hospitals and consolidating their services into a new hospital in Butner. The plan was to shift most mental health care to private providers in community-based programs.
But when the state isn't going to move those dollars to the community level, then you have a complete loss of resources available for folks with psychiatric disabilities in our state.
Most of the dollars were to come from a state mental health trust fund.
The governor had to use the trust fund money that was meant to build up community supports, to pay for hurricane relief and other public safety issues. Well, unfortunately, the downsizing didn't end, but the building up of the community didn't start on time,
leaving a shortage of community care, from inpatient crisis treatment to outpatient therapy. Many patients released from state mental hospitals soon return.
In this time of psychiatric hospital downsizing, we're seeing the highest admission rates in our state's history. Something doesn't add up there.
That's because it's subtraction. Fewer days for patients in state mental hospitals because they are being discharged sooner.
And some of it does have to do with the need to have space. I don't know that there's pressure to do that. I think certainly that is now in the equation with the clinicians.
Christian says that should change when more community programs are in place.
We expect that this will all level out, but it's going to take some time.
Bye-bye.
Meantime, disruptions in her care caused Charlene Lee to have a relapse.
There were a couple of times that I did go back to the hospital, and at those times they could not admit me because they don't have any beds. So I was just kind of left dangling.
Patients, their families, advocates, even those who helped design our state's new system of mental health care say too many patients are left dangling.
We treat our criminals better than we do the mentally ill, because they have a place to go for their health care concerns. The mentally ill sometimes don't.
Next, what happens to those who don't?
You think if you got back on your medication, your perception would not be like that?
Excuse me, man. Hey, yo.
You're watching Focal Point from WRAL News.
With the shortage of community services for the mentally ill and state mental hospitals jammed to capacity, many patients often end up in places they shouldn't be, places where they can't get the care they need. That can make a bad situation even worse. Keith Kernan has paranoid schizophrenia.
It is one of those kind of illnesses that distort your thinking.
When Dorthea Dix Hospital released Keith, his mother couldn't find a place for him in Moore County.
Because we only have one group home that serves 6 individuals in the county.
So she put him in a nursing home where he could get regular monitoring and medication. But the staff there wasn't trained to deal with the mentally ill.
They just know I'm supposed to give these drugs out at this time, but not what these drugs do.
Since reform began, the number of mentally ill patients in adult care and nursing homes has been rising. Advocates say it's bad for them and for the elderly residents they now live with.
They don't understand symptoms of mental illness, so they get frightened.
In some homes, younger mentally ill patients have assaulted elderly residents.
Hey, this is Heidi over at RexER. I'm calling to get an authorization number for one of our patients that needs involuntary commitment tonight.
More of the mentally ill are ending up in hospital emergency rooms, too.
And so we have increased our staff to meet those needs. The psychiatrist has been tied up.
Including psychiatric staff. But the wait to get mentally ill patients in crisis admitted to nearby Dorthea Dix Hospital keeps getting longer.
This patient does have insurance, but we got our refusals because everywhere is full. The beds are full in the community. Our inpatient psychiatric beds at our facilities nearby are overflowing.
You think if you got back on your medication, your perception would not be like that?
Excuse me, man. Hey, yo.
Outreach workers helping the homeless in Durham are seeing more mentally ill people because they have no family support or medical coverage.
It's those who do not have that kind of support or access to that kind of income who are mentally ill, who then become homeless.
People actually come out of the state hospitals when they're in there on the short-term admissions and go to homeless shelters. Nothing good's going to come of that.
Many end up in jail.
Probably every day. It's sort of hard to come up with an accurate number, but there's quite a few, unfortunately.
Local police departments, local sheriff's departments, all of these are feeling the effects of folks not being treated properly through the mental health system.
In May, law enforcement officers shot and killed 23-year-old Stephen Gibson after a robbery and high-speed chase. Just a few days earlier, a hospital clinician agreed with his father that he should be committed. Police took him to Dorthea Dix Hospital, but staff there released him a couple of hours later.
Well, I wish they had kept him in the hospital.
If Gibson had health insurance, he might have been admitted to a private psychiatric hospital.
If you don't have money, you know, it's very hard for you to get, you know, the help you want.
Therapist Jane Finch had a client with severe depression who had been getting comprehensive treatment at her local mental health center.
What matters is that stable relationship over time, because in that stable relationship, the client can trust.
That stability ended when the local mental health services were privatized.
So she goes to this program and the clinician is there that she wants to see, but she can't see the clinician because the program won't take her insurance.
Finch tried to help, but ultimately the disruption in care was too much for her client.
My client did commit suicide. And I know I also was very regretful that the service that had existed before was not there anymore, for a client like her and for other clients like her who now are left with, where do I go? What do I do? And how do I get continuity?
In the past, the public sector was always the last recourse for the toughest clients. In a privatized system, they don't have to take the toughest client. So where is the safety net for them?
Our son is 40 years old and has schizophrenia.
Marianne Kernan finally found a place for her son at a group home in a neighboring county. It's in the tiny town of Star. He gets the care he needs, but little else.
There is no chance for forward movement. There is nowhere to go. There is no work to be had. There's no psychosocial program there. There is no transportation. Same things that you and I enjoy in this life should be available for them.
Where those things are absent, so are the mental health care services.
Companies aren't going to come to Timbuktu without making a profit. That's what companies do. They want to make a profit out of that.
Advocates say that's something the state didn't consider in its rush to reform.
They wanted to do too much, too fast, and they did not ask for the consumers and the consumers' families what would be best.
And it doesn't have to.
Next, the challenges faced by private providers and the controversy surrounding the new local agencies that hire them.
The system wasn't perfect as it was, but this quote-unquote reform of the system could be the most catastrophic thing that's ever happened.
You're watching Focal Point from WRAL News.
Under-reformed local mental health agencies that use state and federal funds to provide care were transformed into agencies that manage care instead. Those so-called local management entities use public money to hire private companies to provide care. But many of the companies are struggling, and there's growing concern about the LMEs that hire them. For 32 years, Rowan Homes cared for developmentally disabled adults in group homes around Salisbury.
32 years of history and relationships now amount to nothing, I guess.
That's because the area's LME, Piedmont Behavioral Health Care, terminated Rowan Homes' contract. Rowan Homes was getting $41 a day per patient to provide care. It wanted $75, citing a state-funded study recommending that rate for the kinds of services it provides.
The third-party clinician that conducted that study and was paid by PBH supported our request, but we were never granted the additional funding to provide services.
Rowan Homes Director Dan Coughlin declined an interview, but a statement released by the agency's Community Relations Director said PBH pays the same rate for the same service to all of its providers, and a new provider was selected because Rowan Homes refused to sign their contract.
I'm going to email the board.
Rowan Homes says it lost its contract because it demanded the rate it needed to properly serve its patients, and because it complained about the lack of state oversight of how PBH spends public money.
For me in my professional career, it's been the most disheartening thing I've ever experienced, because it didn't matter what was right or what was fact. They were doing what they wanted to do because they could do it.
One of the legislators who crafted the reform bill says what's important is that Rowan Homes clients are still being served by the new provider.
If we can have a service provided at a high level for less money, I think that's a responsibility that public servants have to do for taxpayers.
But what about the discretion LMEs have to spend taxpayers' money? The Albemarle Mental Health Center is an LME in northeastern North Carolina that covers 10 of the poorest counties in the state. People living there make an average of $26,000 a year. But the LME was paying its director, Charlie Franklin, $319,000 a year to run an agency that was serving only 4,700 patients. The LME director in Mecklenburg County makes $148,000 a year to run an agency serving nearly 34,000 patients. The governor makes $136,000 a year, and the head of the cabinet agency that oversees the state's entire mental health system makes only $117,000. Franklin did not return our calls. A staffer at his LME, a public agency funded by public money, referred us to a private PR firm in Raleigh it hired for $30,000. The firm emailed a statement saying the LME's salaries are consistent with the state structure for compensation. Not according to the State Office of Personnel. After it asked the LME to bring Franklin's salary in line with state standards, the LME's board cut it to $225,000. But the state says that's still too high. A new provision in this year's state budget is supposed to restrict LME salaries in the future, but the issue raises questions about accountability over the new local agencies spending your money.
Well, I think we have accountability problems at every level.
But INSCO says most of the state's LMEs are spending their money properly, serving patients well, and that competition has brought more choices for patients and lower costs for the state. Still, some fear patient cost supersedes patient need.
It's similar to the national model of managed care, of insurance companies, of the profit makers making the decisions for who gets it, how much they get, who doesn't.
This was handed out yesterday.
Paul Caldwell is the CEO of a private company that's been hired by several LMEs to provide mental health services in 17 counties. He says the state requires physicians to decide who gets services and how much.
So our incentive is to provide the right amount of service based on medical necessity for that individual.
Outside factors that we talked about.
He says his company's biggest challenge is finding enough qualified staff and working with 7 LMEs that each have different rules and procedures.
That causes some degree of difficulty in how we do our business.
So does operating under the state's rate for some services.
Have you ever heard of a community support specialist?
When the state cut the rate for community support services, Triumph had to pull out of 3 counties it once served.
And that rate change basically put us over the edge in that area in terms of being able to make it fiscally.
The state cut the rate to punish providers who hired underqualified staff, but some say the state missed the irony of its action.
The bad providers who are defrauding the system, who are hiring unqualified, low-paid workers, can survive on that low rate. But the good providers who hire master's-level clinicians can't survive.
Some providers have gone bankrupt. Others have just moved on.
Private providers can't survive if they can't pay their bills. If they can't get the money they need to pay the rent and the light and the therapist, then they'll have a constant opening and closing.
When new providers replace old ones, patients get providers they didn't choose. And when they can choose, the decision is more complicated than it used to be. Gone are the days of one-stop shopping for services at the local mental health center.
And that has made for a fragmentation, which is the other side of choice.
Next, surprising candor from the person who's overseen mental health care reform from the beginning.
It was a complete and total transformation of every part of the entire system, and that was required to be implemented immediately. Well, there's no way that that could ever have transpired.
To learn more about the issues covered in this episode of Focal Point, visit WRAL.com, click on News, then Documentaries.
It's been 5 years since reform of our state's mental health system began. Advocates say by now, the system should be in better shape than it's in. But the former secretary of the North Carolina Department of Health and Human Services, whose agency implemented the reform over those 5 years, says such massive change takes longer and doesn't come easy. It's controversial. We interviewed DHHS Secretary Carmen Hooker-Odom just before she left office. As you might expect, she tried to put a positive spin on the reform effort.
It's important for people to recognize that this process has really created some very exciting, innovative, and far-reaching accomplishments.
But a recent report from her own Division of Mental Health said just as many mentally ill patients without health coverage are falling through the cracks in the new system as they were in the old one.
The expectations were very high that the moment the legislation was passed, that within a year, the whole system would be transformed.
But Odom says the state's fiscal crisis that year robbed the system of money that was supposed to build the community care infrastructure that reform depended on.
You can't just take people out of institutions and put them out in communities without that capacity up there.
Odom says local mental health centers dropped services to become managers rather than providers of care too fast.
Well, it became evident that in certain areas and for certain services, that wasn't very wise.
Some patients in those areas were left without the services they needed. In other areas, a flood of private companies competed for the right to provide care.
Some of them have been wonderful, others have been questionable. Some have been very successful, others have gone belly up.
To see a psychiatrist.
Many patients have been confused about where to seek help, and many have had disruptions in their care. Like many advocates, Odom agrees that privatization has left holes in the public safety net for many patients.
I would not want to see the system emerge into a 100% quote managed care system.
Odom admits there's too little oversight of the local agencies that now manage care. She says an LME director making $319,000 a year in one of the poorest regions of the state demonstrates that.
Well, it's obscene, and we have no control over that.
She says the fact that her own agency couldn't control it reveals a major flaw in the system.
These are taxpayers' dollars. They aren't just manufactured in the air. These are taxpayers' dollars. And we as a state should have some control over how that money is being utilized in the administration of this service. If LMEs are indeed going to be the managers of this system, then there has to be some place that they are held accountable.
We want to work very positively.
Odom says there are always going to be problems when undergoing such a massive change of such a large government-run system.
I'm actually pretty optimistic that in 4 or 5 years, as we look back, North Carolina is going to have an exemplary program that shines throughout the nation.
If we put more money into the services that we know work, and if we restore some public safety net, and if we simplify our billing and our funding structure, I think we'll be on the road to improving it.
We're very progressive in so many different areas. There's no reason we can't be progressive in the area of mental health care.
Maybe being progressive is remembering why the system exists to begin with. Our system now refers to mentally ill patients as consumers. Maybe our leaders need to remember that they are really just people. People like Charlene Lee, whose last fall through the cracks left her homeless and without the care she needed.
I don't want to see anybody else die because they feel like there's no hope out there. I don't want to see anybody else die because they feel helpless or because they don't think that they can get the services they need. I don't want to see anybody else die. And I don't want to die either.